So this morning, I am very excited to introduce Dr. Ben Lopman. He is currently a professor of epidemiology and environmental health at the Rollins School of Public Health at Emory University. He received his bachelor's degree in microbiology and cell science from the University of Florida, his master's degree from the London School of Hygiene and Tropical Medicine, and his PhD from the Open University Health Protection Agency in the UK. After 10 years working with the UK public health system, he joined the CDC viral gastroenteritis team with a division of viral diseases, which he's still affiliated with today. His research focuses on vaccines and enteric viruses and mainly targets diarrheal diseases caused by rotavirus and norovirus around the world. And his team employs field studies, statistical analyses, and dynamic mathematical models to address the policy relevant public health research questions in the field. He's really a leader in the field of enteric viruses, but more recently has switched much of his work to focus on the COVID-19 pandemic, as many of us have. And his work has contributed to a number of really important topics. He's worked on frameworks for studying vaccine efficacy for SARS-CoV-2. He's characterized super spreading events. He's estimated the impact of non-pharmaceutical interventions, assisted with university reopening and modeling plans, and also worked on understanding and interpreting serological data, which is what he's, I think, planning to talk about today, and how serology can be used to monitor COVID-19 and inform the pandemic response. So with that, I'll let him take it away.
Terrific. Thank you for that introduction. That is indeed what I was planning to talk about today. I'm really grateful to have the opportunity to meet with this group. Obviously, been following all the terrific work that you all have been doing. I think the kind of interaction with Austin and the State Health Department has been really a kind of interesting model for us all to observe. So really grateful for the invitation to be here virtually. Let me start my screen sharing. Okay, you can see the correct screen now, right? Yeah. Okay, great. And I think, Spencer, you mentioned the kind of format is a kind of 20-minute kind of presentation or so, which is what I planned, but I don't know what you normally do, but if I'm happy to can be interrupted and take questions, comments as we go along. So what I'd like to do is talk about some of the work that we've done using serology to kind of understand the pandemic, where things are at, and both in terms of kind of epidemiology and risk factors, but also thinking about how many people have been infected and what that means for kind of response going forward. My cat is meowing at me now, excuse me. I feel it's Spencer introduced our kind of pre-COVID work already, but I kind of feel like it's obligatory for everyone to say briefly what they did before COVID. So here's a picture of our team, at least our team when we were able to physically get together back in the good old days. So as was mentioned, my work pre-COVID really focused on diarrheal disease, and specifically enteric viruses like rotavirus, which is a big killer of children globally, and norovirus as well, for which vaccines are currently in the pipeline. So what I'd like to discuss today are kind of two studies or two questions. The first, kind of more traditional use of serology, thinking about who's been getting infected. So really kind of risk factor analysis that we've done in the early months of the pandemic. We looking at risk factors for infection among healthcare workers. And then the second topic I want to address is kind of a broader question about how many people have actually been infected, and using serological studies to do that. And one particular kind of methodological thing that I think this group might be interested in is some work we've done to kind of adjust for waning antibodies, which we think is an important phenomenon that's affecting our kind of serology studies. So to state what's probably obvious to this group, serology has its value in that it measures, it's an indicator of historic infection, right? And we know, of course, that infections have been severely undercounted, right? There's limited testing. Of course, that was really acute early on in the epidemic. But to some extent, still an issue today with all symptomatic people not seeking care and getting tested. And then the other piece of it, which is that many infections are asymptomatic or mild, and so those people won't seek care, and so they won't get tested. So serology is really useful for estimating how many people have been infected up to a certain point. Okay. So in the first study I wanted to mention was this work we did in collaboration with our colleagues, mainly the School of Medicine and Emory Healthcare. Emory Healthcare is the biggest provider in the Atlanta area. There are 11 hospitals, 250 locations, and about 25,000 employees. I think about 5,000 of those are physicians and nurses. So really kind of major employer in the area. And really early on in the pandemic, kind of just during and a bit after, towards the end of our first wave here in Georgia, there was sort of voluntary serological testing that was made available to all employees of Emory Healthcare. So it wasn't conducted as a research study. It was actually conducted initially as kind of a quality assurance, quality improvement monitoring by Emory Healthcare. But some limited kind of information was collected in terms of demographics, community exposure, and workplace exposure. So we use this survey to kind of look at these risk factors. So to think about who was getting infected. And again, this was kind of early on in the pandemic. Participation, it was 10,000, about 10,000 healthcare workers participated. So about a third of the workforce. And I'm not going to talk about it here, but a couple of the kind of neat or maybe a little more sophisticated things that we did in this analysis is we did a bias analysis to try to work out, how much of our results could be biased by in 2/3 people not participating, which actually is not that bad for a serology study. So we did, if you want those details, they're in the paper, which was published last month in Annals of Internal Medicine. Anyways, the upshot is that about 5.7% tested positive for antibodies, IgG anti-spike antibodies. But we then adjusted this for imperfect sensitivity, or more importantly, specificity, given the relatively low prevalence. And so our adjusted seroprevalence estimate at that time was about 4%, right? So then we used this data to kind of perform a kind of risk factor analysis to look at what were the kind of drivers of exposure and infection. And I think one of the neat things we were able to do here, because these were all Emory employees, we knew where they lived. And so we mapped people's kind of community exposure to their zip code of residence. And we looked at the cumulative number of reported cases in their zip code, the cumulative incidence in their zip code, up to 2 weeks prior to when they submitted their serology sample, right? So that was how we were able to look at kind of one of the ways we looked at community exposure. And the upshot here is that community exposure was a really substantial risk factor for, again, this is amongst the healthcare worker population, right? So we sort of went into this expecting to find lots of workplace exposure, aerosol generating procedures or working with COVID patients. But the first thing that pops out, and you'll see here, this is kind of from our adjusted analysis, is that community contact with a person known or suspected to have COVID-19 is a risk factor. That community incidence measure that I mentioned in the last slide, also associated odds ratio of 1.5 per log 10 community incidence difference. And then this is again in our kind of adjusted models, this is amongst healthcare workers after accounting for these sort of proxies of community exposure. Black individuals, Black Emory healthcare employees were still at double the risk, double the odds of infection compared to the referent white category. I think most interestingly, and what surprised us, is that there were no workplace exposures that were associated with infection. We spent a lot of time kind of looking at workplace exposures, given the data that we had. We had information on whether someone cared for a COVID-19 positive patient, whether they were in contact with other healthcare workers who they knew to be positive. We looked at all the different locations, what their workplace role, whether they were registered nurses, whether they were generating, involved in aerosol generating procedures, their kind of reported PPE use, and none of these seem to be associated with infection in that first wave as well. During the kind of, I think we're in more of a crisis period for many healthcare workers. So this really kind of surprised us. Was, I guess, in a sense, good news for Emory Healthcare, but I think a bit surprising. I'll just mention that we have a similar study from nursing homes, which I won't talk about, or won't show data from, where we found quite different findings, actually, that in nursing homes, healthcare workers, care providers, actually strong evidence that they're getting infected in the facility. So a real contrast here to acute care.
Ben, is this only of those 5,000 physicians you mentioned, or is this of all staff members?
No, so it was amongst all staff members. About 10,000 were healthcare workers who participated. Yeah.
Thanks.
Yeah. Any other comments or questions before I move on to the next topic?
Would you think that this is due to PPE effectiveness or other types of protocols in the workplace?
Yeah, I mean, I think it's in these kinds of studies kind of not really possible to identify anything. In fact, we didn't find that PPE was protective either. This was sort of self-reported PPE on these surveys. My take, and my collaborators who are kind of much closer to the clinical interface, is that it's really just a kind of range of infection control that was put into place in terms of cohorting the COVID-19 patients, strict adherence, at least, had pretty high reporting of PPE use. So I think it's a combination of things, and I think it's continued as well at Emory. And I should say we actually combined this analysis with 3 other kind of large healthcare providers, and in a combined analysis actually found very similar things. We didn't find workplace exposures being particularly important again, but community exposure and race also kind of consistent across sites. That's actually something that surprised me, given that these are like Emory, these are all employees of Emory Healthcare. But I think I learned that there's still a lot of kind of inequity, different kinds of exposures by race, even amongst sort of professional healthcare worker class. Okay, so the second topic I wanted to talk about is that it's kind of this bigger question of how many people have been infected with SARS-CoV-2. And this is sort of an evergreen topic, and I think we're obviously thinking about it a lot now in the context of herd immunity, how many people need to get vaccinated in order for us to kind of be able to contain community transmission, right? So we started thinking about this question, how many people were infected from conducting a community-based serology study, seroprevalence study, really in the early days of the epidemic. So we started this project called COVIDview, which is a kind of spin-off of a established research group at Emory on HIV. So they have a project called AIDSview. And what was so unique and what we kind of leveraged in this study is that they've developed a really rigorous national probability household-based sampling framework. So no doubt you've heard a lot about serology studies that have been conducted in the US and elsewhere, but I think especially in the US, the studies that we've seen probably have a high likelihood of bias, right? I mean, those earliest sero surveys that did things like recruitment on Facebook, so lots of potential bias in that kind of convenience sampling. Then, there's sort of hospital-based leftover clinical samples are used too, and you can imagine those have their own biases. So, we really leverage this COVIDview framework to conduct this probability sample of 4,500 US households. So in the project, we sent these first an invitation and then a kit out to these households. One member would be randomly selected, one adult member, I should say. They complete a survey on their kind of behaviors, what prevention methods they use, their occupation, demographics, and then they do a sort of self-administered dried blood spot draw and sends it to our lab for antibody testing. Right. So one thing we gave no thought to when we started this study back in kind of late spring, summer last year was the issue of kind of waning antibodies. And as time has gone on, we realized this could be a really kind of major threat to the validity of this project. So it's something we gave a lot of thought to. Just to put this in context, this is you all may be familiar that the CDC is conducting ongoing serological surveillance. You can sort of access the data on this website. They're using these sort of discarded samples from commercial labs, and they're updating their seroprevalence estimates every 2 weeks. But again, these are sort of convenient samples left over from clinical testing, other clinical testing, and not COVID related. And one thing we observed, and others have as well, is that starting over the kind of summer period, we started to see in the CDC surveillance, as well as in other studies, declining seroprevalence, right? Now, seroprevalence is meant to be, serology is meant to be an indicator of historical infection, and prevalence is declining. Something's wrong, right? It means that, there's a few potential explanations, but this was observed kind of in New York, which was, hardest hit. Seroprevalence started to come down, hardest hit in the early phase of the pandemic. Similar findings were in the REACT study, this community-based study in the UK. Also saw sort of declining seroprevalence over kind of late summer and fall. And what we think is behind that is antibody waning, such that people at some point, they have an infection, they are seropositive, and then at some point they serorevert, and their antibodies drop below the limit of detection that are used in these serology studies, right? So this is data. This was kind of early data published by CDC from healthcare workers who were followed up over over a 60-day period, and fully a third of them went from seropositive to seronegative in a 60-day period. There's been a number of other studies that have confirmed this. I will say there's been some studies that have shown really durable antibody as well. So there's some kind of discrepancy in the data here. At any rate, and the sort of balance of evidence, we thought this was an important thing to take into account. And so we developed a model, kind of statistical model that would convert our seroprevalence estimates to cumulative incidence, taking into account waning antibody. So essentially what the model does is, let's see if I can point here. So the model kind of follows the kind of natural history of this process, right? A person gets infected. At some point thereafter, they have symptom onset, and then they seroconvert. So we use data from other studies to kind of inform our model here. How the time from onset to seroconversion, which is about 11.5 days. After they become positive, there's this longer and unknown period as to how long they stay seropositive and then serorevert, as we call it. Their antibodies drop below detectable levels, right? So this is the thing that we're estimating the mean of that in this framework, right? In order to do this, we also use mortality data, and I'll explain how that fits into this framework. So first, one thing we need to know for the model is the kind of distribution of time from onset to death. For this, we use data from the Georgia Department of Public Health, who is actually collaborating quite closely with Emory on a number of analyses. And so from that really kind of substantial data set, we estimate this distribution from onset of symptoms to timing of death. And then basically we put that into this framework to essentially back calculate, using the death time series, we sort of back calculate the timing of onset of those reported deaths, right? So we go from reported deaths to when the time of onset would have been, okay? And I'll say we use deaths because we think it's a reliable, a fairly reliable source of consistent source of reporting over time, where cases were obviously much more subject to testing availability, lack of availability early on. So I won't go into this for this audience here, but this was a slide to explain to our public health colleagues the kind of Bayesian framework in which it's implemented. And essentially we estimate in the framework the infection fatality ratio, right? And again, this is in this kind of Bayesian framework. We estimate the infection fatality ratio. That second value, the duration of seropositivity, or the time to seroreversion, right? So from that, we take our mortality data, we kind of essentially back calculate to when people got infected, and then we sort of scale that up to case counts using this inferred infection fatality ratio. And so this is an example of this approach plotted on the right. This kind of seroreverted cases, the seroconverted cases, and then the true cases in blue when the case onsets. When the times of infection actually occurred, estimated to have occurred. Okay, so we first kind of developed this using that CDC serology data from early on in the epidemic. We developed this framework first in New York City and in Connecticut. And again, you can see that pattern here of the declining seroprevalence. It kind of rises up quickly to over 20% and then begins to decline. And then the model sort of fits the daily seroprevalence. And as you can see, the model does capture that decline. And then the red line shows the cumulative incidence inferred from the sort of prevalence estimates. So you see the value, you see the sort of time trends in New York, as well as Connecticut. Connecticut was nice because they actually had more samples going out a little bit further at the time that we developed this algorithm. Okay, so we developed this and then we used it on our COVID view data. And the thing with COVID view is this is a national probability sample. We only now we have a single seroprevalence estimate. We only conducted one round of the study, although 2 more rounds are planned. So here are the results from the first round, and employing this, this framework that I just introduced. So first of all, we estimate the infection fatality ratio. The model estimates it to be 0.64%. You can see the 95% credible interval there. So this is actually quite in line with other estimates. We unfortunately at this point have not been able to generate kind of age or race specific infection fatality ratios, but the plan is to do that over time. And one thing I absolutely should have mentioned earlier is that this framework was developed by postdoc working in our team, Keiko Shiota, who's really done all the kind of brain power and model implementation that I just discussed. And here's our kind of cumulative incidence curve, similar to the ones I showed for New York and Connecticut, for which we had more samples, but here we're applying it now to this kind of more representative national probability sample. First of all, I'll tell you it's not plotted on this figure here, but we estimated about 5.5% seroprevalence at the time. But when we correct for that, when we correct for kind of under seroreversion, and you look at the estimated cumulative incidence, you see our estimated incidence as of October 30th is about 12% of the population in the US had been infected, right? So if we compare that to cases reported to that time, this is the midpoint of our survey, by the way, the COVID survey. If we compare that to cases that had been reported to that point, we estimate 17% reporting fraction, right? And that means, just to put this into sort of national scale, by the end of November, about 40 million Americans had been infected out of 330 million or so. So this, I just mentioned this work is ongoing. We actually have, we're conducting a second round of the serosurvey now. We also have an oversample in California, in Georgia, and a few other states. So we're at the moment generating state-specific estimates. And in fact, we just yesterday presented our case, our Georgia analysis to Governor Kemp, which I think was really important because there've been the governor's liked to focus on the case reports, and we've always been kind of reminding how much underreporting there is, and even how much even if you had good ascertainment of cases, how much asymptomatic infection there is. And so I think this was really valuable to get this information in front of the governor, as governors are making these decisions about reopening, like Governor Abbott in Texas, like we just heard about. So the last thing, I'm just going to mention it in case we want to have spend some more time discussing it, is nothing I've talked about so far is really kind of transmission modeling, but we are doing some transmission modeling work, which is kind of leveraging serology. And this is some work that was led by Alicia Cray and Kristen Nelson in our group, in collaboration with Joshua Weitz, who I think may have spoken at one of these meetings in the past. Joshua Weitz and his group have developed this notion of kind of shield immunity, the notion of kind of intentionally deploying immune individuals in order to kind of control community transmission most effectively. We have taken that notion a little bit further in collaboration with him and his group by thinking about how you could use serological testing to identify immune individuals or immune populations and sort of preferentially kind of reduce non-pharmaceutical interventions through either knowledge of individual status or knowing kind of seroprevalence or, the number of immune people, the proportion of immune people in a given population. And so what this figure shows here is that kind of if you kind of leverage serological data, you can roll back, you can reduce NPIs and social distancing and resume more social contacts with a lot less risk if you can do it by informing, who is being released from social distancing, who's going back to work, who is going into office, who's going out and having more contacts by identifying their sero status. So again, I won't, in the interest of time, won't go into detail about that, but happy to talk about it further. And I'll just wrap up by maybe stating some things that are obvious, which is that we think serology has been a useful tool for identifying risk factors for infection. We're now employing this to estimate cumulative incidence. And as I mentioned, less than 1 in 5 infections have been reported nationally by the 1st of November 2020. And like I mentioned, the last thing I mentioned is that we think this data can help us to kind of inform the drawdown of the safer drawdown of NPIs. And the final question I thought others might want to discuss is how we're going to use serosurveys going forward when vaccine is introduced and when it will be more difficult, more difficult than impossible to tell whether immunity is from natural exposure or vaccination, and all the kind of complex temporal dynamics that come with with antibody waning comes with that. So with that, I want to acknowledge the many people who were involved in the work that I presented, most specifically Alicia Cray, who did the transmission modeling, Keiko Shioda, who developed the waning immunity cumulative incidence framework, and Julia Baker and Kristen Nelson, who led on the healthcare worker risk factor study, and other Emory and collaborators elsewhere. And thank you for your attention.